all I'm going to do here is give you an introduction to Dr. Duane. He's been with the NSTA since way back in, I think it was 1984. He's a behavioral neurologist with a great deal of background and interest in focal dystonias, essential tremor, tics, these kinds of movement disorders that many of us have, including myself. So his education was initially at the University of Michigan, and then followed through with a master's degree at University of Minnesota, and then finally worked at the Mayo Graduate School of Medicine. And following that, he joined the staff at the Mayo Clinic in Rochester, Minnesota, and became an Associate Professor of Neurology at the Mayo Medical School. So after some years there, in 1987, he moved to Scottsdale, Arizona, and he established the Arizona Dystonia Institute and became an adjunct professor at the Arizona State University. He's published many, many papers, written or contributed to many books and published letters, edited many books on topics in neurology. So he's a great guy to have with us today, making a presentation for you on the whole spectrum of the issues and the problems and the treatments for movement disorders, and specifically in our case, spasmodic torticollis, or as it's otherwise known as cervical dystonia. So we have a long resume on all the things that he's done here, all the research that he's done, and everything. We'll post this on the NSTA website if you want to look at it in real detail. But I don't want to take any more of his time, giving you all of this time. I think what you really want to know is what he's going to be presenting to you. So with that, I will turn the presentation over to Dr. Duane. Thank you very much, Doctor.
Thank you. And friends, welcome to those of you here in the Mountain States and West Coast. Good morning. And for those of you who are further east of us, good afternoon. I hope the presentation today is helpful to your understanding of an uncommon disorder that when I started getting involved with it as a very, very young person on the staff at Mayo, nobody knew very much about cervical dystonia, spasmodic torticollis. And a very important force for you patients and your families has been NSTA, which has been very forceful in trying to disseminate information so that each of you have a better understanding, as well as stimulating National Institutes of Health and various organizations to sponsor research in uncovering the cause and the most effective treatment for this uncommon and sometimes quite painful disorder. And we're going to talk today about what patients have taught me. And that's because when I started, not very many people knew about torticollis in medicine. Certainly I didn't. And all that I've learned over these years is what I've learned listening to patients or asking them questions, and what the summation of their answers led us to understand about this condition. On this first slide, on the left, you've got an image of the Gamage Auditorium at Arizona State University, the campus in the middle of the University of Arizona College of Medicine, the branch here in Phoenix. And on the extreme right is the image of the building where for 21 years we occupied space on the third floor, where many of our cervical dystonia spasmodic torticollis patients were evaluated. The results I'm going to share with you come then from two sites of origin. One in Rochester, Minnesota, involved patients that came to Mayo for treatment and diagnosis. And then a group of patients that we saw here in Arizona, both of them in the numbering in the hundreds. And all of them that I'm going to describe to you are patients I physically saw, examined, and most of them have been seen on multiple occasions. The top part of this slide refers to the population that we reported published in 1988. They are a group of patients initially seen for an experimental treatment called iontophoresis of the inner ear. Having just joined the staff at Mayo, I was asked to serve as an evaluator for how effective this new treatment for torticollis was, At that point, I knew nothing about cervical dystonia. But within a short period of time, I had seen 200 patients with this condition. We took a sample of 50 patients who we reported in the mid-1970s who had received a special program in physical therapy at Mayo, along with two of my colleagues who were physiatrists on the staff, Dr. Scott, Steve Scott, and also Mershid Senaki. And then finally, a group of patients I saw in 1985. But in between, we were constantly seeing patients with spasmodic torticollis. We took these 3 samples, and they numbered 347 individuals. A number of observations were made, including this one, which shows that there were more women with this condition in this referral population. That's not how it occurs within a city, for instance, but with this referral population, 2 out of 3 patients were female. When we looked at the age of onset of their symptoms, you notice that the peak is somewhere between 40 and 50 years, and the average for women was 43.5 years, the average for men, 42 years, and later in life, earlier in life, the numbers were much lower. So more than half the patients, somewhere between 35 and 55 years of age, is when their symptoms would have begun. And the question would be, why would that time in life be so important for this condition to begin? And why would it be more common in women? There were several more observations that we made, and that we reported in 1988 became the focus of our investigation when we moved to Arizona to continue the work with developmental disorders and continue the work with focal cervical dystonia. Now, here's a bunch of people who have crooked necks. Do they all have ST? Well, they might, but a better answer is no, they have a museum with crooked pictures and they're trying to make the pictures look straight. Interestingly, we've had patients who said they've understood that they had torticollis when the photographs they took showed that everyone was slightly tilted to one side. Or one woman who was a sculptress, all the busts that she carved were slightly tilted to one side as her head was. It changed their visual perception. But the point here is that there are many conditions for which the term torticollis, twisted neck, could be used, but they aren't all what you people have. They aren't all spasmodic torticollis, or as we say in medicine, cervical dystonia. To look at what the incidence was within a given population, a study was done using David Claypool as the major investigator. David was a patient who came to me as a student at Rochester Community College. He was dyslexic and he needed to be certified as dyslexic so the school would modify his education. Not so much reading, more time to read, yet he was a bright boy, went on to Hamline University, and then became one of the earliest acceptances for the Mayo Medical School in Rochester. In his 3rd year, he came to me, he said, Dr. Duane, I have to have a project before I can graduate. Do you have any ideas? I said, well, we've got this epidemiologic survey for Olmsted County here in southeastern Minnesota. Why don't you look and see how frequent does torticollis occur? And there were many, many, many people, several hundred, for whom on their chart the word torticollis appeared. But some had acute wry neck. They woke up this way. 2 weeks later, they were back to normal. Some had been in motor vehicle accidents. They had a stiff neck with spasm, but within a matter of weeks to months, their symptoms had abated. They did not have cervical dystonia, but there were 11 over this 25-year span of time who did. And in this community, 9 were women, 2 were men. So prevalence was even higher in females in this small population. One of the women herself has a head tremor. Her mother has had tremor. No torticollis, just a shaky head. And you're going to hear more about shaky heads in a little bit. Well, how frequent is it around the world? Number one, our colleagues at the University of Oregon took our data and went through all of that Olmsted County epidemiologic survey and looked at the other forms of generalized and localized forms of dystonia. Here was oral mandibular, the jaw is moving, writer's cramp, the hand is affected, spasmodic dysphonia, and we've got some SD people who are in our audience today. Generalized forms of dystonia, essential blepharospasm, where the eyes keep closing. That seems so low, and most of us feel that's too low an estimate. But what was the most common? Spasmodic torticollis, cervical dystonia, 89 per million. And we estimated that's a minimum estimate for the world at large. So here's a better one, perhaps. Justin, why am I not moving? There we go. Let's go back. This was a study that was done in Oslo, Norway. Here they had a total of 129 cases of localized forms of dystonia. What's number one in frequency? Cervical, ST. Half those patients were cervical forms of dystonia. What's the gender ratio? Almost 2 to 1, as we saw in Minnesota. Mean age of onset, 41.2 years. Very similar to what we saw in the Minnesota referral population. And it was the same with regards to the age of onset in the Olmsted County Epidemiologic Survey. You say, well, 13, that's a smaller number. Yeah, but it's per 100,000. So if we convert it to what we had, 89 per million in the Olmsted group, here it's 130 per million. And that's a more accurate estimate, we think, of what the true frequency of occurrence for every million of population, there will be at least 130 individuals who have this disorder. Well, we've seen this slide. Why are we going back to it? Because I want you to look at the bottom part. This slope. Notice there are more males that had their onset here than the females. Well, what does that mean? What's so special about them? Well, colleagues in the United Kingdom came up with a study. And they said, let's take a look at people who start with their neck condition before the age of 21 or 28. And out of that group of 650 in total, 76, 12% had earlier age onset. Look at the gender split, more males than females. But the caveat here is, in the United Kingdom, males tend to slightly in a higher frequency of occurrence of cervical dystonia than females, different than we have in North America. Mean age of onset of these young people was 21 years of age. Family history of tremor or dystonia, 1/4 of them. Depression or anxiety in the patients by history, and 1/4 of them. Injury with pain, surgery around the head or neck, less than a year before the onset, in 17%. Remissions, that's a period of time of 3 months or longer in which, for all intents and purposes, that person no longer has their symptoms of cervical dystonia. 1/3 of them. It's never that high in the big population going through all the ages of onset. So there's something about these people where it goes away, but remissions can occur at any age. Oftentimes, unfortunately, coming back. What does remission mean? It means it's not like Parkinson's disease. It's not like Alzheimer's disease, which are progressive degenerative disorders of the brain. Whatever is going on in the brain of the typical dystonic localized form of dystonic patient, their condition is not destroying brain tissue. It may be physiologically or biochemically out of sync, but it isn't being destroyed. And that's why these conditions are usually not progressive. What was odd about this group really was frequency of which arm dystonia co-occurred. We don't usually see that high of frequency in our general population of torticollis sufferers. So 13% is rather high. DIT1 gene, what's that? There's a gene locus on the 8th chromosome that's been associated with generalized forms of dystonia. Could this be part of that gene? Because that one may express itself in childhood. So in 15 of their cases, that gene was looked for, it was not present. How about a trial of L-Dopa? Well, that's a medicine for Parkinson's disease, but it's also a medicine that's effective for a condition that in childhood is dystonic, where a child in the afternoon finds one foot wants to rotate as they walk. As time goes by, the same side of the body, upper limb, may also get involved, but later in the day, not first thing in the morning. If you follow these people into adulthood, they develop rest tremor, shuffling gait, soft voice. They have what looks like Parkinson's disease. So it is called Dopa-sensitive dystonia. Is this one of those? No. L-Dopa therapy, and for our cervical dystonia patients, over and over again, trials of L-Dopa have been made, never had a good effect, sometimes upsetting their stomach, but not changing their cervical dystonia. Well, how frequent is this early age onset? And could we verify that in North America, they're similar to the ones described in the United Kingdom? So from our population seen in Rochester, that segment of all the patients I saw that numbered 347, 47 of them, or 13%, had onset by age 30 or younger. Here, the frequency is still higher in females than males, but closer to each other. So more males, like that blue line suggested. What was their mean age of onset? Just like the ones in the United Kingdom, age 21. What was the family history? Just of dystonia. A quarter of them had relatives that had dystonia. How about family history of shaking, tremor? A third of them had shaking, tremor. Depression or anxiety in the patients themselves, before they even had cervical dystonia, 40%. Head, neck, or shoulder injury, less than a year before, 15%. Neck surgery with pain, 6 of them were 13%. And that began to raise the question, does injury, not affecting the nervous system, but causing pain, cause cervical dystonia? In that same population, look how often was remission. 20 of them, that's 43%. 3 months or longer without a recurrence during that time, but at some point, the symptoms came back. Where else was there dystonic symptoms besides the neck? Again, in this group, we had 8, a quarter of them, total 12, 26%, who had some site other than the neck that was involved. Head tremor, now in the patients, a quarter of them. Hand tremor, in a fifth of them. Here we were starting to look now at the health of the entire spine, not only at the time we saw them, but if we saw patients over and over again every 3 to 5 years, we would x-ray the entire spine again. What's happened? What was it like to begin with? And what were the extent of wear and tear changes? And what we saw was scoliosis, curvature of the spine, in more than a third. CT, we had no MRI yet. In 15, all were normal. So they were primary, not secondary to some injury to the brain, a stroke, tumor. They were like all of you in the audience, idiopathic, unknown cause, primary forms of dystonia. Well, there's our Gamage Auditorium here Arizona State University. So how many patients did we see here in Scottsdale? And how many of them had early onset forms of cervical dystonia? Well, we had 305 at this point, and 9% of them, 28, had early age onset before the age of 30. And again, both males and females, more females, but almost equal number of males. And that's different than we see later in life onset. Mean age of onset, just like our Rochester experience, and just like the United Kingdom study, 21 was the age. All three identical. Family history of dystonia in a fifth, family history of tremor in 40% almost, depression or anxiety in the patients in a fifth of them, painful trauma, 21%, evidence. Now, all of our patients now here in Arizona, we're doing personality, cognitive measures, following the x-rays of their spine, and we know whether or not they are having, at the time we see them, evidence of depression or anxiety, and it's 43%. And recognize, we're not saying that's the cause of their dystonia. And that was one of the terrible things we observed at the outset of an experience with our patients. They were misunderstood. If they had anxiety or they had depression, it was given as the cause of their condition. And it isn't. It is a combined attribute of people who develop cervical dystonia. How about the frequency of remission in this 305 that were seen by us in Arizona? That's 29%, much higher than we would see in the general population of cervical dystonia patients. Again, arm involvement, that's brachial means arm. And then some involving the spine. So they had axial, meaning the entire vertebral column was twisted, as well as the head being tilted to one side. Head tremor in a quarter of them. Hand tremor in 18%. Scoliosis in almost 30%. MRI of the head done in 4 of them, all negative. CTs in 5, all negative. DIT1 gene looked for in 4, at that chromosome 8 site. It's not that condition. But we'll talk a little bit more about that in a bit. This is a cartoon given to me by a patient from Dallas, Texas, that I cared for in Rochester. She subsequently came to surgical treatment with Dr. Claude Bertrand in Montreal. And I was privileged to assist Dr. Bertrand in carrying out the surgery, just holding retractors, not doing anything more than that. But this cartoon says, apart from your neck, how are you feeling generally? Well, here's our take on this. It doesn't take a lot of sophistication to recognize somebody's head is turning or tilted, pulling back or forward. What I want to know is what else in that person distinguishes who they are and may tell us why the neck is doing what it's doing in that small number, maybe 130 per million at any given point in time. Here's a chest X-ray that is expanded, and notice that there is a curve to the thoracic portion of the spine. This is a person who has cervical dystonia, ST, spasmodic torticollis. Same person. Oh my God, we treated them well. Look, that's a cure. No, they're lying down. And what we saw very early on, postural changes make a difference in how active the muscles are. Not for everybody, but in the majority. So lying down for many, not all, muscles relax. Hopping up and down, the neck straightens. Lying on a table or on a bed, letting the head dangle over the edge, muscles relax. Why is that important? Because during that time, you can do your range of motion exercises greater than you can when you are upright, when the muscles are most actively turning the head against you so that you can't go through the full range of motion. That doesn't cure torticollis, but it keeps your joints along the side of the neck, these joints from fusing, because they will over time. And then you can't straighten the head. And that's something that Carlos Arce used to do before he would do selective denervation surgery on people. He would put them under a general anesthetic. Your muscles will relax then. And if he could not straighten the neck under general anesthesia, he wouldn't do the surgery because he knew the neck had fused because of so many years being in this altered posture, and relieving the muscle spasm was not going to be of help. And so he wouldn't put the person through a difficult, long operation. Here are some things, as time was going by, we learned about spasmodic torticollis, that about 20% of people described a year or so, but not more, year or less prior to the onset of their neck symptoms, they had had a painful neck injury. One guy was walking through a gate and there was an arm that came down and struck him in the head, knocked him over. Within a matter of a few days, his head started to turn. A patient of ours from Germany had a house under construction. He fell through the floor on the first floor down to the basement. Jerking him around like this, didn't lose consciousness. And a week later, his head started to turn. Well, did that cause cervical dystonia? And we're going to investigate, was it a cause? Remission occurs maybe in the general population, 5 to 15%, but if you're a youngster and this condition begins young, it may be as high as 40% that you'll have a remission. By the way, remember that woman we described from Rochester who had the head tremor and her mom had head tremor? That patient also had iontophoresis treatment. She went into remission, and as of 5 years ago, so that's a period of almost 40 years, she has been in remission. Botulinum toxin, whether it's A form of toxin, B form of the toxin, F form of the toxin, which is made in Japan, 90% successful in reducing at least 2 of the 4 symptoms of cervical dystonia by 50% or more. And when toxin works, it takes 1 to 2 weeks before it's going to help. Best, pain. Second best, range of motion. Third best and iffy, posture. Least successful, changing tremor. But there are ways in which you can modify the way you give the toxin, causing each of those to be successfully improved for the duration of time the toxin works, anywhere from 2 to 3 to 4 to 6 months from the time of injection. What's MHPG? It is a breakdown product of the body that appears in the urine. It comes from noradrenaline. We measured serotonin breakdown product and noradrenaline breakdown products in our patients here in Arizona, shipped the urine samples to Rochester. The laboratory there assessed them and said, you know, their serotonin levels are okay, 5-HIAA is normal, but this MHPG is lower than the general population. So medicines that work on noradrenaline, imipramine, nortriptyline, doxepin, are agents that sometimes prove of help, watching carefully for any potential side effects. What's DBH? Well, it's not a car, it's dopamine beta hydroxylase, and it's a compound that is involved in dopamine metabolism. Well, we know that dopamine runs out of people with Parkinson's. Is there something screwy about dopamine metabolism in our patients? Like, why do our patients have blue, green, gray, or hazel eyes, but not brown? DBH levels were tested by Dick Wenzelbaum, who was doing a study at Mayo, for about 20 of our patients, and all of them, it was normal. And the conclusion was that enzyme is not important in cervical forms of dystonia. We were looking as early as 1990 in depth at cognitive function in patients with cervical dystonia. That means, how do they think? Measures of learning, remembering. Measures of copying figures, remembering them. doing numbers going forward and then back, concentration. And what we found is these anticholinergic medicines like artane, cogentin, benztropine, trihexyphenyl, procyclidine, all had the possibility of causing slight, even at low dose, reductions in memory function. At high doses, it was very common. Our concern was, does that mean people with cervical dystonia are low in their brain of acetylcholine and they're unusually sensitive to 5 milligrams of 0.5 milligrams of cogentin, 5 milligrams of Parsidol, which is procyclidine? The last point, there are so many conditions now we recognize of the brain that come from antibodies made by the person against their own tissues, so-called autoimmune disorders. To look at that, we looked at antibodies against the thyroid, against the antinuclear antibody, against the rheumatoid factor, and against the neuromuscular junction. And we'll report to you, what did we find? Could cervical dystonia be an autoimmune disorder or not? Whoop, that's the three stooges. Well, this slide we could use to say, this is what physical therapy can do for you. Or we can use that slide to say, what's the effect of trauma and pain and its association with the onset of cervical dystonia? At this point, we had in Arizona 198 subjects in this study. And the numbers will change because at different points in time, the studies were done. And we had 42 or 21% that had a history of pain, trauma that was persistent over a year or less, but not more, and developed subsequently then their cervical dystonia. And we went through 24 different comparisons between these two groups. Gender, 76% female, 74% female. Mean age of onset, 45, 43. Symptom duration when we saw them, 10 years, 9 years. Light eyes, blue, green, gray, hazel, 70.5%, 78.5%. Almost identical. And through all of the 24, now 20 additional factors we compared, they were virtually identical. No difference, except for the history of a painful injury that hadn't damaged the nervous system, just caused pain. What could we conclude? That the two groups are similar. Therefore, pain is not the cause of cervical dystonia, but pain may be for individuals at risk for cervical dystonia to have it trigger the onset. That's different than what is the cause. Trigger, not cause. By the way, on this color of eyes issue, when we did a similar study reported in Buenos Aires of Parkinson's disease patients, 60% of Parkinson's patients in our study had brown eyes. Whoop. There's a guy with a long neck and he's got an acute stiff neck, or RY, W-R-Y, neck. We'd have patients who would call us, Dr. Duane, it's a tragedy. My granddaughter was just born and she's got torticollis. What she has is congenital RY neck or congenital torticollis, a benign disorder that is not dystonia. It's due to shortening of the muscles due to probably the lie in the womb. And with heat massage therapy, it disappears, and these kids have no risk for developing cervical dystonia down the road. None of the ones we're aware of ever develop cervical forms of dystonia. So it's a separate benign condition. Worrisome, surely, but not related to any other relative in the family who happens to have true spasmodic torticollis. Well, what about this question of autoimmune antibodies in people who've got cervical dystonia? Here we took 254 cervical dystonia patients. We matched them to 137 people that we called controls. They usually had head or neck pain. They were similar in age, 55, 52, gender split of the populations, more women than men, anti-nuclear antibody that occurs in lupus and other conditions, but may occur on its own without an illness, at a level that's more than 1 to 80, meaning more than 1 to 160. 24% of the girls, 23% of the boys, versus controls 10 and 8%. When you see P, that means what's the statistical significance? 0.005 means only 5 chances in 1,000 that this represents chance. So there is a reason why these two populations are different. They are different with regards to this property. They are not similar, but they're not as strikingly different with regards to the thyroid antibody, more than 1 to 400, meaning more than 1 to 800, 10.5%, 7.5%, 5.7 women, men. These are higher, and borderline statistical significance, rheumatoid factor was more common in this group. But what about this neuromuscular junction receptor antibody? Well, I ask crazy questions sometimes. And I said, well, if we're going to shoot these people up with botulinum toxin, that stuff could injure their neuromuscular junction. And I had done a lot of work with myasthenia gravis, a disorder that is autoimmune, and was a co-author in the paper that described antibodies against the junction between the nerve and the muscle that cause the weakness that occurred in people with myasthenia gravis, droopy eyelids, double vision, something on their speech like lens, weakness after exercise. So we screened 48 patients for this neuromuscular junction receptor antibody, because if you have myasthenia gravis, you're not supposed to get botulinum toxin therapy. That's a contraindication, just like ALS is. The receptor antibody was found in 4 of those 48. That's a rare antibody. That should only occur in people who have myasthenia gravis. One of those 4 also had single fiber EMG by Dr. Clark Stevens at Mayo, who was visiting here in Arizona from Rochester. And Clark said, this woman has the neuromuscular junction defect we see in myasthenia gravis. She had received botulinum toxin therapy, but did not get excessively weak. What's the explanation? Not certain. We know it's not the cause. That is, people have been on medicines for autoimmune disorders like steroids and develop cervical dystonia. People have received steroids and other immune suppressant medicines while they have cervical dystonia, and it doesn't change, strikingly, their cervical dystonia. So that would argue against the condition being that way. Well, what could the connection be? The connection might be there's a link between the propensity, the tendency to make self-immune antibodies like ANA, this one at the neuromuscular junction, linked to the gene, if there is a gene, related to why people develop cervical dystonia. In a study in which I'm a co-author with colleagues at Baylor University, we found a gene factor on chromosome 6 in many patients. That's the chromosome that's involved in making antibodies. Oh my God, this poor family, the whole family, including their dog, has cervical dystonia. No, they just have a crooked Christmas tree. Whew. Thank God. What about family history? Family history does not prove a genetic cause. It raises that possibility, but it's never a proof. Secondly, family history without actually examining the family member is anecdotal information. People giving us the information are not medically trained. They may be accurate in what they describe, but their interpretation of what they saw could be off. So it's helpful, but not definitive. But what about family history in our patients? Here's a family tree. This is the oldest generation. That's the father and mother of this generation. Wow, a lot of kids. They lived in Nebraska, not too far, many in Omaha and around Omaha. This man is described as having a head that shook. Mom, he's of German ancestry, Scotch-Irish ancestry. She has no evidence of any head or neck problem. I flew to New York to attend a movement disorder meeting, but I stopped off in Omaha, got a hotel room, and over 2 days, I examined each of these people. And this is what we found. Here's our index case that I had seen originally in Rochester. He has cervical dystonia, no tremor. His brother next to him has both head tremor and torticollis. This brother has cervical dystonia, torticollis. This sister has curvature of the spine of scoliosis, no dystonia. This sister has a granddaughter by history with scoliosis. This man has a son who's asymptomatic, a daughter with cervical dystonia, a daughter with scoliosis. We have examined and gotten blood from both of them, raising the possibility, could there be a link between shaking and surely scoliosis in people with cervical dystonia in their family, as though the gene was a partial expression. And the old terminology was called a form frust, a partial expression of a gene. So these people, their blood was analyzed in London, England, where we had it shipped. Nick Wood took over that laboratory, and 2 years later, he told me they could not find an association. And I feel bad that we didn't, at that time, yet have our association with TGen here in Phoenix, a great genetics group where we might have been able to find, with today's technology, what was the gene locus for this family and their condition that might be important to other patients with cervical dystonia. And why is genetics important? Once you know the gene, you can figure out sometimes what is the biochemical or physiologic deficit. And the reason why the connection to scoliosis is important is as follows. Here's real scoliosis. And this is a girl from Dallas, Texas, also, not the one I referred to previously. She has scoliosis. She's got 4 sisters. 3 of them have scoliosis. She has cervical dystonia, axial dystonia, and left upper extremity dystonia. Her symptoms began at the age of 10 after a fall. In a short time, they disappeared. After a fall, they came back in late adolescence. It disappeared. And then it returned in her early 20s after a fall and has never disappeared since. So she's like that early age onset group of patients. Pain as a trigger, symptoms come and go. She has had periods of remission, and then it stuck with her. Toxin helped her, but she became resistant to the toxin because the early forms had a higher protein content than they do now. We sent her to the University of California, San Francisco, and I attended deep brain stimulation as a treatment for her. The treatment was successful without complication to the patient, but the benefits, if any, were minimal. And so for her, that was not an effective form of treatment. Oral medications and physical therapy for her have been the most helpful, but using toxin more judiciously now might have been able to prevent her becoming resistant. Well, how frequent is scoliosis in cervical dystonia patients? Now here we've got 292 cervical dystonia patients at this point in this study, 150 controls, neck and spine pain patients. What's their personal history that they were told as an adolescent they had curvature of the spine? 12%, 2%. That's statistically significant. Observed scoliosis, because we have spine x-ray of the entire spine, in 16.5% versus 3%. That's statistically significant. History of scoliosis in a brother or sister, 7%, 1%. That's statistically significant. History of scoliosis in an offspring, a child, 11%, 2%. That's statistically significant. History of scoliosis, both a sibling and an offspring, 5.5%. That's very statistically significant. Furthermore, studies done by colleagues in Boston looking at a physiologic property common to patients who have dystonic symptoms of the neck and patients who have idiopathic adolescent onset scoliosis, they have the same physiologic property of the brain as seen in those with cervical dystonia. Therefore, there is a link physiologically between these two. We will sometimes inject, going back to that image, muscles along the spine when people have pain, and where we have EMG recordings that have shown where the muscle overactivity is, and the use of botulinum toxin may help them with less pain. We wondered, could botulinum toxin in adolescents along the spine avoid the need for surgery, painful surgery, in these children? To be determined. It helps chickens. We don't know if it is safe and effective for human beings. This is tremor. This is a tremometer. It's recording a rhythmic oscillation at 5.5 cycles per second. Our patients have it done on their hand as it's extended, on their head and neck, in various postures, and we do not use the word tremor unless we see for 2 seconds or longer a fixed rate movement like this, so that just jerking occasionally doesn't count. That's a dystonic movement, it's not a tremor. So this group of people we're going to describe have this kind of movement. One group are ET. Now that's not the extraterrestrial. That is essential tremor, the condition like Katharine Hepburn had that affected her voice, and her head, and her hands, and ran in her family. It's a benign disorder. It is not Parkinson's. Our CD patients who also have tremor. And then our CD patients who don't have tremor, at least at the time we've seen them. Where in their family is there tremor? In these patients, usually the hands. In our patients, could be hands, but way more than this group, a head tremor. Where does head tremor tend to occur? 6 times more frequently in females than males. What's more frequent in the United States for cervical dystonia? Females 2 to 1 versus males. How about the frequency of dystonia in their family history? Again, that's anecdotal. Most of them have not been actually examined by us. 16%, 10% versus 2, that's significant. Scoliosis, borderline 0.09. Parkinson's disease, high in all. This group seems higher, but it's not statistically different from the control group of essential tremor. How about the patients themselves? These people, it's in their hands. Our patients, it's in the head or in the head and the hands. So tremor is frequent, and tremor more frequent to be head only, but may include hands. The third area that can be affected potentially is voice. Well, we said that depression was seen historically in so many patients. What's the link, if any, between depression and patients with localized forms of dystonia? Here's our three groups: essential tremor, cervical dystonia with tremor, cervical dystonia no tremor. And what we see is this: 31%, 35% family history alleged to be depressed. Alcohol abuse, where depression is common, higher in our two dystonia groups. But in the patients themselves, look at all three. Half meet criteria. These are on standardized psychological tests. They're anxious people, like Don Knox was in that TV series. All three of them are anxious. But look at depression, frequent, but 84%, 62%. That is statistically significant with this number of people. Well, why would depression be there? Well, if your neck did what you didn't want it to do, why wouldn't it make you nervous? Why might you not also be depressed? There's another reason. Remember that DIT1 gene we talked about that's seen in generalized forms of dystonia? That gene has what's called 40% penetrance. That means 60% of the people who have that gene never get dystonia. But that 60% of patients have a statistically high rate of major depressive disorder. So the gene that causes dystonia is linked to a cause for depression. It could be, speculation, that there is a link between whatever gene factors are involved in our focal dystonia patients, voice, face, neck, that could be the reason why depression may even be there before there were neck symptoms. What about treatment? Some people who have mild forms of cervical dystonia, which we saw in the Rochester study, that is not the referral patients. The patients who developed it, some of them were very, very mild. It would never get this treatment. Many of my patients, we have never treated with botulinum toxin. The first line of treatment is physical therapy. Some simple medications that relax muscles can be of help, not curative, none of them. This treatment is not curative, but you should know about it because it's so commonly employed. If you have moderate, if you have painful cervical dystonia, this treatment has a high probability of being helpful to you. Botox is a brand name. Dysport is a brand name from Great Britain, the company owned by a French family. This was owned by the state of Michigan Department of Health, now owned by a pharmaceutical firm, Solstice, called Myoblock. It's the B form of the toxin. In Germany, feeling that the amount of protein that's present in these, highest in this one's got 100 units, 500 units, 5,000 units. And that's not because it takes more, it's just the way they're measured. This one matched to this one, but probably not exactly equivalent. At 100 units per vial, it has virtually no protein. That being the case, it should have essentially no risk of producing antibodies against the toxin that would cause the person to lose the benefit. Where is there the risk? When that is given in less than 3 months. That's why FDA says get your injection at least 90 days or more after your prior injection, because shorter than that, you increase the chance that antibodies that negate the effect of the toxin will occur. Mentor is a corporation that developed a form of A toxin that was purchased by Johnson J&J. It, so far as we know, has never been brought to market. Physical therapy, anticholinergic medicines, benzodiazepine medicines, antidepressants that have the effect on noradrenaline could be of help, such as doxepin, nortriptyline. Let me get a sip here. and imipramine are agents that sometimes have been helpful not only to the mood problem if it's there, but can be helpful to the movement disorder. Physical therapy makes absolute sense. The difficulty is most physical therapists don't know anything about cervical dystonia. So you have to teach them. Kathy Brewer and I did a 3-hour workshop one year when the Physical Therapy Association had its meeting in San Diego. And we did a workshop on treating patients with cervical dystonia because when we didn't have the capacity to use male physical therapy, we developed our own physical therapy program at that point with a protocol that was helpful. And it should be used regularly, not because it's curative, but because it is helpful. And anytime a patient with this condition feels they have better control of their neck, and as a consequence of their life, they're going to do better. How do we know which muscles to inject? We record them. And here you're seeing 2 muscles being recorded. We will do 6 pairs of muscles, right and left, around the neck and down the spine in many instances, so up to 10 pairs of muscles may be evaluated before we ever inject. Once we know which muscles are most active, what the pattern of the dystonia is, those are the ones we inject, and we don't need the needle again. The sternocleidomastoid does not require a needle before you know which muscle to inject. It is a big, obvious muscle to inject. You just got to make sure you choose the right one, right or left. Sometimes both have to be injected. Here's what the recording shows you. This muscle called the splenius capitis on the right, on the left. If they were injected, this muscle would get more than this one. Maybe this would get 37.5 units. This one might get 12.5 units of botulinum toxin. That way we know we have the best chance of controlling the person's cervical dystonic symptoms. And depending upon the total dose, which would for Botox brand will be somewhere between 250 to 300 units. For women, maybe 200 to 212.5. And for Dysport, anywhere from 500 to 750, occasionally 1,000 units. But don't worry, that's not a high number. I mean, the number's high, but it's not a high dose. It's measured differently in the British toxin than it is from the American toxin. Well, what's wrong with this lady? Well, her head is turned a little bit, tilted a little bit. She is a torticollis sufferer. But why is she furrowing her forehead, raising her eyebrows? Well, because we asked her to. And that's because 2 weeks before, we injected in the frontalis muscle here 25 units of botulinum toxin A and 1,500 units of botulinum toxin B. She'd been treated successfully at one point with each of those, became resistant to this, became resistant to this. This proves she has circulating antibodies to both A and B. It's called the frontalis test, which we described in the mid-1990s as a test that could be used to find out if there are circulating antibodies. It could be more precise, but it is helpful. The most precise is with a mouse protective antibody, but no insurance company will pay for it. Well, if you have antibodies, your toxin will not work for you. We had evidence some people were developing antibodies. Could we protect them so that they would still get a response from their toxin injection? This slide reports the case report of 11 cases of patients who had become resistant, not totally so, but somewhat resistant to their toxin injections. We had measurements by frontalis test and by mouth protective antibodies suggestive of resistance on the basis of antibodies. Back in Rochester, there was a physician patient of mine who was in training at the University of Wisconsin in Madison. And Randy has voice, neck, hand dystonia. Brilliant young man. He went on to California, which was his home state, became a member of the University of California, San Francisco staff, and along with Dr. Shumway, where there were heart transplants going on, he monitored their immune response with the medicines to try to allow the body to accept someone else's heart so they might live. I contacted Randy and I said, Randy, I want to give somebody the safest form of immunosuppression I can give them, maybe 3 days before, the day of, and for a week after their injection, to see, can we preserve their response by blunting the effect of the antibodies we know they already have? He said, pick mycophenolate. And so we used mycophenolate, a very commonly form of treatment for liver transplant, kidney transplant, heart transplant patients. 250 milligrams, 3 times a day, 3 days before, the day of, 5 to 7 days after. It was tolerated. No one got seriously ill, thank God, because we were monitoring their health, checking blood effects on blood-forming elements, liver function. Most, not all, of these patients, we were able to preserve the response. We reported that in the year 2000. Glenn Heinberg, our young man who was working with us, a student at ASU, who became a medical student in Omaha, Nebraska. No one has picked up on that. And among the reasons is we don't inject patients as frequently anymore. And as a consequence, they're at lower risk to develop immune responses based on antibody formation. But if that becomes an issue again, this is a potential or other agents that we could consider to try to preserve the response to botulinum toxin. But you're going to have concerns about other forms of treatment that include physical therapy, that include oral medications where there's tremor, benzodiazepines like clonazepam, small dose, propranolol, small dose, in combination with a small dose of an anticholinergic, and we like procyclidine, no longer available in the United States. Our patients get it from a Canadian pharmacy. It's cheap, and it's better tolerated, and it has some degree of benefit for many patients with dystonia, no matter where the focal dystonia is. Well, we've covered a lot in an hour and almost 10 minutes, but we've only uncovered the tip of the iceberg, if you will, of cervical and other forms of focal dystonia. But I've learned this because so many of you were open about yourselves, your families, cooperated with our studies, knowing that through these studies, we might eventually have the answer, why does this condition occur? How can we prevent it? Or if it develops, how can we cure or minimize its impact on patients' lives? Thanks so much for your attention. I hope it was useful.